Welcome to our first video on cyanotic congenital heart diseases. Let's begin. These are the topics we're going to cover in this lecture. Let's start with Tetralogy of Fallot. We're going to discuss introduction, clinical presentation, diagnosis, treatment, and complications of Tetralogy of Fallot. Tetralogy of Fallot is the most common cyanotic congenital heart disease. It is a combination of multiple defects including overriding of aorta, pulmonary stenosis, right ventricular hypertrophy, and ventricular septal defect. Pulmonary stenosis is the most important prognostic factor because the degree of stenosis determines the degree of oxygenation and thus severity of disease. Tetralogy of Fallot is mostly sporadic. However, it is highly associated with Down and DiGeorge syndromes. Here's an illustration showing the four classical features of Tetralogy of Fallot. Notice that there is pulmonic stenosis, right ventricular hypertrophy, overriding aorta, and VSD. Recall that all this occurs due to antero-superior deviation of infundibular septum. Clinical presentation mostly depends upon the degree of right ventricular outflow obstruction, as we previously emphasized. Babies can present with cyanosis and hypercyanotic TET spells. Cyanosis indicates the low levels of oxygen in the blood and is detected by the bluish discoloration of the skin and mucous membranes in the neonate. TET spells are sudden and profound hypoxia, occurring during activities that cause decreased systemic vascular resistance or increased pulmonary vascular resistance, such as crying, defecation, or feeding. The low systemic resistance or high pulmonary resistance increase the right to left shunt and thus the cyanosis. Tetralogy of Fallot, or TOF, can also lead to heart failure where babies present with irritability, poor feeding, and lethargy. Clinical clues are very important for the diagnosis and can be auscultated. Typical harsh crescendo-decrescendo systolic murmur at left lower sternal border is heard. Single S2 can also be evident. Let's discuss the diagnosis. Hyperoxia test is an easy way to rule out the pulmonary causes of cyanosis. Infant is placed on 100% oxygen concentration for about 5 to 10 minutes. If the partial pressure of oxygen rises to 100 or higher, this indicates presence of possible pulmonary causes. However, if the hypoxia is persistent and partial pressure of oxygen remains below 100, it suggests presence of right to left shunting. Chest X-ray shows boot-shaped heart due to right ventricular hypertrophy and upturned cardiac apex. There is also decreased pulmonary vascular markings due to pulmonary stenosis and decreased blood flow through the pulmonic valve. ECG reveals right axis deviation due to right ventricular hypertrophy. Echocardiography is best for the confirmation, and it can measure the pressure gradient of right ventricular outflow tract. This chest X-ray is showing the classical boot-shaped heart, which is seen in Tetralogy of Fallot. Let's move on to the treatment section. For TET spells, knee chest position or squatting is very useful as it increases the systemic vascular resistance favoring left to right shunting. Other supportive measures include morphine, oxygen, intravenous fluids, and beta blockers. Surgical intervention is required by the age of 1 year. It includes ventricular septal defect repair and surgical resection of infundibular muscle bundles to relieve the right ventricular outflow obstruction. However, if early surgery is not possible, Blalock-Taussig shunt is created, which connects subclavian artery and pulmonary artery. Complications include heart failure and infective endocarditis. A risk of arrhythmias can be present following surgical repair. Let's try a question. A 1-year-old boy is brought to the physician by his parents due to poor feeding and lethargy. He was born at home 39 weeks of gestation. Mother reports that her baby becomes blue whenever he cries, and she has to push his legs close to his chest to relieve bluish discoloration. An echocardiography reveals ventricular septal defect, overriding aorta, pulmonary infundibular stenosis, and right ventricular hypertrophy. What is the most likely diagnosis? This infant is brought to the physician due to poor feeding and lethargy. An echocardiography reveals ventricular septal defect, overriding aorta, pulmonary infundibular stenosis, and the right ventricular hypertrophy. These four findings are classic components of Tetralogy of Fallot. Mother reports that her baby becomes blue whenever he cries. This is the phenomenon known as TET spell, caused by right ventricular outflow obstruction in patient with Tetralogy of Fallot. The mother has to push the infant's legs close to his chest to relieve bluish discoloration. This is because squatting increases systemic vascular resistance, decreases right to left shunt, and improves oxygenation. So the most likely diagnosis here is Tetralogy of Fallot. Next we have transposition of the great vessels. We're going to discuss introduction, clinical presentation, diagnosis, and treatment of transposition of the great vessels. It is characterized by an arterial switch. The deoxygenated blood from the right ventricle enters the aorta, whereas the oxygenated blood from the left ventricle enters the pulmonary artery. It occurs due to failure of aortopulmonary septum to spiral during the cardiac development. For the infant to survive, a kind of shunt is needed, for example, ASD, VSD, or PDA. This will make sure that a portion of oxygenated blood enters the systemic circulation. transposition of great vessels is mostly seen in infants of diabetic mothers and is most common in male babies. Here's an illustration showing transposition of great vessels. Notice that the aorta is arising from right ventricle and the pulmonary artery is arising from left ventricle. This is opposite to what we see in a normal heart. Cyanosis is the most common clinical finding but is not specific. The cyanosis shows no response to supplemental oxygen and is not affected by exertion. Other clinical clues include oscillatory findings such as loud and single heart sound. Usually there is no murmur, unless there is another defect such as ventricular septal defect. Let's discuss the diagnosis. Chest X-ray shows a typical egg on a string appearance of heart, egg being the enlarged globular heart and string being the narrow superior mediastinum. However, ECG mostly shows normal findings. Echocardiography is the confirmatory test as it detects the abnormal location of aorta and pulmonary artery. This chest X-ray is showing the classic egg on a string appearance, which is seen in transposition of great vessels. Treatment involves prostaglandin E1 infusion to maintain the patency of patent ductus arteriosus. These will help maintain the oxygen saturation. Similarly, NSAIDs should be avoided. Delayed surgical intervention is associated with poor outcome, hence should be performed within the first 2 weeks of life. Surgical procedure is determined by the presence of other cardiac defects such as ventricular septal defect and left ventricular outflow tract obstruction. Let's do a review question. A 2-hour-old infant is evaluated in the newborn intensive care unit due to diffuse cyanosis and lethargy. He was born at term without any complications. Echocardiography reveals the aorta arising from the right ventricle and the pulmonary trunk arising from the left ventricle, and patent ductus arteriosus. Which medication should immediately be administered to enhance this patient's survival until surgery. This 2-hour-old infant is evaluated in the newborn intensive care unit due to diffuse cyanosis and lethargy. Echocardiography reveals the aorta arising from the right ventricle and the pulmonary trunk arising from the left ventricle, and the patent ductus arteriosus. These findings are classic for transposition of great vessels. This condition involves complete separation of systemic and pulmonary circuits, so it is incompatible with life unless the shunt-like PDA is present. Therefore, we need to maintain the patent ductus arteriosus until surgery is performed. Ductus arteriosus is kept open by prostaglandins E1 and E2, so one should administer PGE1 analog like misoprostol or alprostadil. Let's end our lecture with a board-style question. A 2-hour-old newborn is evaluated in the nursery for diffuse cyanosis. She was born at 38 weeks of gestation via spontaneous vaginal delivery. Mother had no prenatal complications. The patient's vital signs include a temperature of 37 degrees Celsius, blood pressure of 65/50, heart rate of 145, and respiratory rate of 50. Physical exam reveals exacerbation of cyanosis during strong cry. Cardiac auscultation shows holosystolic murmur at left lower sternal border as well as crescendo-decrescendo systolic murmur at the right upper sternal border. The echocardiography reveals right ventricular hypertrophy as well as overriding aorta. Which of the following is the most important prognostic factor in this patient? A. Ventricular septal defect. B. Right ventricular hypertrophy. C. Pulmonary infundibular stenosis. Or D. Overriding aorta. This 2-hour-old newborn is evaluated in the nursery for diffuse cyanosis. Her vital signs are normal for the newborn. The physical exam reveals exacerbation of cyanosis during strong cry. This phenomenon is known as a TET spell. Cardiac auscultation shows holosystolic murmur at the left lower sternal border, which suggests ventricular septal defect. There is also a crescendo-decrescendo systolic murmur at the right upper sternal border, which is consistent with pulmonary stenosis. The echocardiography reveals the right ventricular hypertrophy as well as overriding aorta. Ventricular septal defect, pulmonary infundibular stenosis, right ventricular hypertrophy, and the overriding aorta are consistent with Tetralogy of Fallot. The most important prognostic factor for Tetralogy of Fallot is the degree of pulmonary infundibular stenosis. In other words, the more stenotic the right ventricular outflow tract is, the less oxygenation occurs in the lungs, which in turn leads to increased risk of death. Therefore, the correct answer is option C. Here is a slide reminding us of the clinical features of Tetralogy of Fallot. Pause the video and take a moment to consider this slide once more. Let's discuss why other options are incorrect. Options A, B, and D are incorrect because although ventricular septal defect, right ventricular hypertrophy, and overriding aorta are all present in Tetralogy of Fallot, none of them is the most important prognostic factor for the patient's survival. And that concludes our lecture on cyanotic congenital heart diseases.